Hi, everyone. Thank you all for joining. This webinar is from the Global Observatory of Long-Term Care. Specifically, this is from the Pain and Care Home Special Interest Group. And Adelina Comas Herrera is the director of the observatory, but unfortunately, she isn't able to attend today. My name is Naz, and I work as the research coordinator at the Global Observatory on Long-Term Care, and we'll be doing a quick introduction of the observatory. So, the Global Observatory of Long-Term Care is an initiative of the International Long-Term Care Policy Network. And the idea behind the observatory is to harness the collaboration that many of us had through long-term care COVID and now focus on tackling wider long-term care challenges. So, the aims of the platform are for cross-national learning. And that is to identify key shared challenges and showcase how different countries and localities are addressing them, and to share evidence and facilitate collaboration. This is an area that's open to anyone interested in long-term care, including policymakers, people in industry, advocates, care professionals, and academics. And the membership for the GOLTC is free, so I'll be sharing links in the chat during the webinar. And there are many ways that you can engage with the observatory, including sharing publications, country profiles, and joining special interest groups. I'll leave that there quickly. And then for our upcoming events, so on Thursday, we have a joint collaboration with the Global Observatory of Long-Term Care and the Integrated Long-Term Care Interest Group, and that is from 12 to 1:30. And then on Friday, June 20th, the interest group on care and social protection in Southern Africa will be having a webinar. And up on the 24th of June, we have a collaboration with the WHO, and they will be doing community-based care resources. And finally, on July 2nd, there will be a webinar from the interest group on quality improvement. But most importantly, coming back to today, we have the Pain and Care Homes interest group that will be doing intelligent pain assessment. So I will be passing it over to Manu.
Hello and welcome everybody, also from my side. I'm very happy that this is the first webinar in the second year, and I see a lot of people also coming in. So happy to share all the informations and all the resources we have with you. So if there are any questions according to the interest group for pain and care homes, do not hesitate to write me an email. I will help you forward. On behalf of Sandra Zwakallen and myself, I'm very happy that today we have a very special guest. I think this is a really interesting topic. It's about intelligent pain assessment. And everybody who is working directly with residents in long-term care know that, especially with patients with cognitive impairment, it's pretty difficult to assess if they're in pain and about the pain intensity. So this might be one application, one form that we will use in future times in long-term care to help us specifically in the group of cognitively impaired persons. So Jeff, thank you once more to sharing your resources, your time, and your knowledge with us. And I would say the floor is yours.
Thanks, Manuela, for those words of introduction. I thank you for the invitation and for the interest, and I'll tell you about the Pain Check story from where we are, where we started, and to where we are at the moment, and where we're looking to go to in the future. We're always interested in collaborating with people. Kresnik Hodi, who's one of the other Pain Check inventors, is located in Europe. He's in Kosovo at the University of Pristina, and he's always happy to engage with people within Europe. So I'm an emeritus professor in the Curtin Medical School, Curtin University in Perth, Western Australia, and I'll talk about a little bit about that in a moment. But I used to be the former head of School of Pharmacy, and before I entered academia, I was the head of clinical pharmacy services at Sir Charles Gardner Hospital, which is a major tertiary hospital in Perth. And in 2021, I left academia and joined Pain Check as its chief scientific officer. And I'll talk a bit more about that. But just to familiarize yourself with Perth, it's this little red dot here. What's it famous for? It's said to be the most remote capital city in the world. We have about 2.2 million people, so it's not small. In a state as big as this, which is bigger than many countries in Europe, with about 3 million people. This is a picture of the Perth foreshore. This is what's called Victoria Keys. So we've got a lovely city, looks idyllic as it is, and I've lived there all my life, so I'm a big advocate for Perth. But if that doesn't, if you got no idea about Perth, then you'll know this person. This is Roger Federer, and he is taking a selfie with these guys. These are quokkas. This is on Rottnest Island, which when the Dutch arrived thought they were rats, so they called it Ratnest Island, and it's been from that. So that made Perth particularly famous, but so did these two guys. This fellow here is Barry Marshall, and this is Robin Warren, and they are the people who discovered Helicobacter, the cause of peptic ulcer disease. And Barry Marshall worked in a hospital about 5 miles from where I worked at Sir Charles Gardner Hospital, and it took about 15 years for that discovery to become practice in the hospital I was in. This is Curtin University, where I used to work, and still have that affiliation. It's the biggest university in Western Australia. It's not a particularly old university. It's in the top 100 young universities, that is, universities of less than 50 years of age. To introduce, this is Mustafa Rati. He was the PhD student who was involved in this project. He was displaced from Iraq because of the war, and prior to taking up and doing his degree in pharmacy at Curtin, he'd done 3 years of medicine in Iraq. This is Kresnik Hodi. He was displaced from Kosovo because of the war. He too was doing medicine, but became a pharmacist. Kresnik was my first ever PhD student, and Mustafa, what's his name, supervised Mustafa with myself. Back then I had more hair, and this is when I was head of the School of Pharmacy. It's obviously been more stressful being the Chief Scientific Officer of Pain Check. And that's really where we began with our idea. So Curtin University was where we started with Pain Check. But I suppose the question is, why would 3 pharmacists be interested in this particular topic? So when I started at Curtin University, as I said, I'd been a hospital pharmacist. I started doing medication management reviews in aged care facilities, and it was at the point in time, so it's 1997. The new atypical antipsychotic drugs had appeared, risperidone, olanzapine, quetiapine. They had no adverse effects, according to anyone who knew nothing. And so we used lots of them. And all I saw was escalation in their use, together with benzodiazepines, use a lot of antidepressants, particularly SSRIs, and in combination with drugs that cause problems, particularly tramadol and oxycodone at that point in time. But no real logic around management of pain, just the presence. But these tablets here that I've got in the picture, they're paracetamol tablets, and they worry me a lot in older people, because what you do is you get those 2 paracetamol tablets, you crush them up in that little mortar and pestle, you put them in jam, and then you place them in the mouth of a person who's got advanced dementia, who might be mute and cannot swallow. And their mouth is dry as a bone because of all the other medications they can. And that tiny fragments of that sit in their mouth. It's so bitter. When Mustafa came along to me in 2010 to say he wanted to do a PhD, what I suggested, I said to him, I've got the project for you. We're going to improve pain management in people with dementia by improving pain assessment. And that's where we began. And it's really around the things that you already know. Pain is very common in people with dementia, in people in aged care. Up to 80% of people with dementia have chronic pain. And in the community setting, it's 50% based in the literature, or more than that. And as we know, and as Manuela alluded to, pain assessment in people with dementia can be extremely challenging because of diminished language capacity, memory impairment, and behavioural symptoms that can lead to that difficulty in articulating pain. And as a consequence, caregivers and clinicians may not recognise or interpret the expression of pain and miss the opportunity really to treat it. Part of the reason comes in the next bit. So we don't adequately assess it, we don't adequately treat it. And of course, pain is an unmet need. And if we don't treat it effectively, then we continue to have the issues that we'd have. And I think it's all well and good that we have these definitions of behavioural and psychological symptoms of dementia. Terminology changes, we move it to behaviour and psychological symptoms. And then we call them challenging behaviours, which means that the patient is the person, not patient, I shouldn't say, is the problem, and it's not that the case at all. Then the behaviours with purpose, and then we really understand their behaviours that relate to unmet need. Pain is one of those, but there's multitude of other things. And, you know, I've seen many, many patients with dementia sitting in a chair beside the window because it would be nice for them to look outside, but it is 35 degrees outside and they've been on antipsychotic drug. Their internal temperature is increasing because their thermoregulation is impacted by the antipsychotic drugs they've got. We need to understand these people are persons and they have unmet needs. And then when I arrived at the university, I was teaching geriatric pharmacology and geriatric pharmacy and talking about dementia and psychological and behavioural and psychological symptoms of dementia. And the literature says up to 90% of people will suffer from these particular symptoms. And so it's much easier to accept that changes in behaviour relate to a progression in the disease with not necessarily considering other antecedents. And, you know, some time ago when I was teaching this, if you have someone who's got dementia in early age in 40, then they've normally got one underlying cause of their cognitive impairment, the disease which is causing that. And that might be syphilis, it might be AIDS. But in somebody who's 85, who's got dementia, then about half of their cognitive impairment may be related specifically to other conditions that they have, heart failure, a whole range of other conditions. And one of those is pain. So 1997, we've got all this information. 2002, the American Geriatric Society puts out common behaviours in cognitively impaired elderly persons. And so this forms the basis, or a number of these form the basis for a whole range of pain scales that we have. But I highlighted everything on the red over here just to emphasise the fact that behavioural and psychological symptoms of dementia can well be manifestations of pain. And so that's what drives what we wanted to do. We wanted to ensure that we could remove unnecessary use of antipsychotic drugs and other psychotropics, better manage people's pain, and where possible, remove those challenging behaviours or responsive behaviours because of unmet need. So our starting point, we wanted to develop a pain assessment system. Initially, we called it EPAT, Electronic Pain Assessment Tool, but now it's known as Pain Check. We wanted a point of care application. So at that point in time, back in 2010, the use of smartphones was pervasive, and products such as the Android phones, Samsung phones had fantastic cameras and high processing. So it was capable, we could do that. We wanted to utilize AI for the facial expression indicative of pain, and we wanted to combine that with the non-facial indicators. And we were using digital checklists because we wanted a digital profile of a person's pain. You know, a lot of mistakes are made up when you add up pain scales. So we wanted to remove that as a potential cause of error. And we wanted to assign pain intensity so that we had high levels of clinical utility. And we wanted to document everything into the cloud because that allows sharing of information it provides this opportunity for connectivity. So we set our conceptual framework. So we looked at the subjective nature of pain. We looked and considered that multidimensionality and the complexity and the dynamic nature. It's important to think through that point because AI is really at that point in time is only focusing or mainly focusing on facial expression. And we know that in people who've got pain, first of all, they're stoic faces. So we need to understand there will be other expression of pain. And we had read through the literature to see that it was best to assess pain using a more comprehensive set of indicators, and hence we use the American Geriatric Society behaviours of people cognitive impairment as the basis to improve that comprehensiveness. The temporality of pain was important to us. So we know that pain is generally lower when someone is resting, increases with nociception. So we wanted to be able to document pain both at rest and post-movement so that we've got a much more comprehensive clinical picture of the patient. We wanted to use as best objective descriptors as possible. So we looked at facial actual coding system, which there was a large amount of information, but also a lot of consideration that at this point in time, if we're going to use fixed cameras, that was going to be a problem. And we had a plan to get around that. We looked at what was available in the literature. We did a review of all of the currently available pain assessment tools to find those which had the most sensitive for the presence and intensity of pain. And then we worked on the basis of a simple scoring system. So it's the similar way of the PACSLAC. We used a binary system because it's very difficult, you know. If you're an elderly patient and you've got a permanent wrinkles on your forehead like me, you might look like you're frowning. And how do I know if that's a mild frown, a moderate frown, or a severe frown? Or do I just accept that you're just a grumpy old man and the frowning is part of your life? So we wanted to make it, the person looks like they've got a facial expression, AU4, so brow lowering, and they just have to hit the presence. And that's, the literature said that that was less prone to error and improved accuracy. So we went down that path. The other things we wanted to work on were looking at cognification, so integrating artificial intelligence or effective computing, and that allowed us to do the facial detection and the analysis, and then to use smart computing, which allows us to do the digital checklists and the computation of the pain score and assigning of the pain intensity, and the Internet of Things. So the Internet of Things gives you connectivity and allows people to share information in real time and increases the opportunity to reduce simple tasks that can be automated, but at the same time improve communication and better management of patients. The automation of, I can't read half of it because your face is in front of it, of the facial action coding system was focused on because we know that coding of a minute of a video by a skilled coder takes about an hour. So in clinical settings, that's not particularly useful. Not to say that you can't actually teach people to code at a much more macro level by looking at anatomical features of the face. The other thing we wanted to do, we wanted to use smart devices. Smart devices are pervasive. People have good literacy in their use. They're small, they're cost effective. A small tablet costs less than 300 Australian dollars, which is about 200 euro. So they're relatively cost effective in that way, and they're easy to use. And because they're connected to the internet, we get this interoperability. We wanted to use the Internet of Things and cloud computing because that allows us to manage data in real time, and that also allows us to transfer data to and from patients' electronic medical records, and that saves time. And we wanted to have an app that didn't need to have the internet. So all of the processing for our tool, all of the facial analysis is all done on the app, and it can be done anywhere, anytime, without connectivity to the internet. But as soon as you become connected with the internet, then what you get at that point in time is it synchronizes back to the cloud storage. So what we got was an on-device assessment, no internet required, mobile technology. We know that there's good digital literacy, although there are a number of people in aged care who are acting as carers or nurses who don't have a particularly high level of digital literacy. So we have to work and train those people. It's flexible deployment, and as I said, that interoperability. This is what our tool comprises of. We have our face domain, 9 AU codes based on the literature, and we utilize their AI's facial detection analysis. And we have a 3-second video scan of the face, and that produces the results. No collection of facial images, no transfer of that data off the device. And then 5 other domains, the voice, which is 9, movement 7, behaviours 7, activity 4, and the body 6, which means we've got 42 items. And as I said, these are based on AGS guidelines and other existing tools and literature review. Binary score, so the score is either 0 and 1, so the total score is between 0 and 42. Automated pain scoring, and these assignments of pain intensity come from calibration against the Abbey pain scale. We've got pain profiling, which I showed you before, and we've got pain charting. So we can chart the pain for the people, and we synchronize it all onto the cloud. So all going well. This is a little demonstration. This has come straight off a video from the app. So this is a patient profile. So you can see the date of when the patient's pain was assessed. You can see the time it was assessed. This is a pain score of 14, and it represents moderate pain. And this symbol here says this is a post-movement assessment, and it was done using a video. Here it's post-movement, but it was a manual assessment in this particular person. And we have manual assessments because on certain occasions, people are moving too much, lighting is poor, other funny things happen, and we can't do it. So a little video, and this represents our Pain Check Universal. So it has a numerical rating scale for those people where we can get self-assessment. So let me tap that. Check the assess button, check pain check, do a post-movement assessment. It analyzes the face as soon as we do that. Comes up with 5 action units in this particular person. Swipe left, person's making noisy sounds, they're groaning, moaning, and they're sighing. They're restless, they've abnormal walking, they're confused, they're distressed, they're resisting care, they've had a recent fall, so they've got a painful injury, and they have osteoarthritis, and that gives you the score. And you can go back and click on each of these. This was done by automated, so you can't change them, but if you think there are other items or want to remove an item, you can do so. You save it and go straight back into patient profile in real time, and is transferred to the patient record. So we have this in Android and iOS. It can operate on a phone, it can operate on a tablet. We have this web admin portal, which collects all the metadata from it. We have an open API that allows us to interact with electronic medical records. We can also interact with people's electronic medication chart. And we train everyone to use Pain Check, and we've trained over 16,000 people to use it, and we provide ongoing support. And we monitor people's performance in the use of the app, and we benchmark them against other facilities if they want to do so. So this is where we start. So I told you 2010, Mustafa comes to see me to do a PhD. He had to finish one more year of his master's, and then he could start doing his PhD. He enrolls in late 2011, and in early 2012, We've conceived what we think the app will look like. We put in a application to Alzheimer's Australia, and they give us $50,000, which is our first validation that someone believes that we need this. Mustafa also got a PhD scholarship from them, and he was also offered a PhD scholarship from the Australian Pain Society, which is, again, a further validation that this was worthwhile. Kresnik spends his time looking for people who can build this app for us and finds a group in Switzerland called Inviso. They've won an award from IBM for their work in facial recognition and analysis, but their initial work was on testing the impact of texture and taste on baby food and facial expression in children. So when we tell them that it's exactly the same as building a pain app, they are pretty excited, and they started. And this is in about July, and by November, we have a prototype. And immediately we get the prototype, we do this piece of research. We have 43 people who've got chronic pain, and we get them to record their level of pain using numerical rating scale, the VAS, and the verbal descriptor scale, blinded to us. They put that in an envelope with further details about their pain and their pain management, and we do a facial analysis. And this is a picture of our first prototype app. And what that demonstrates is that when people have 3 or more facial indicators based on the facial analysis, it's highly predictive that they have high levels of pain. That's either moderate or severe pain, with sensitivity and specificity in the 90% range. So with that, we then need to raise more money because we've got to develop it. This is a good idea, but it's not going to go forward without further money. So we raise $500,000 in seed funding, and we start a company called EPAP Proprietary Limited based on that initial data. And then we start to refine the app itself, build more functionality, and we build the back end so that we can have that interconnectivity and multiple users. And we do validation studies where against Abbey Pain Scale, where we have 2 independent blinded assessors doing simultaneous assessments using both those tools. And I'll talk about that results. 2016, EPAP becomes a publicly listed company, which is now known as PainCheck. And in 2017, in July, based on these studies that we did here, we get regulatory clearance as a Class 1 medical device in Australia with the TGA, and with CE mark in Europe, and we're the first ever pain assessment tool to have regulatory clearance. So that's July. And in September, Dementia Support Australia, that provides services, consulting services to aged care facilities and people living in the community who are caring for people with dementia who develop challenging behaviours, take on PainCheck, replacing Abbey Pain Scale. And as a result of one of their consultations, a nursing home in South Australia, Barossa Village, takes on PainCheck in November of the same year. This slide just provides you with the studies that we did. We have good concurrent validity against Abbey Pain Scale. The correlation coefficient is somewhere between 0.81 to 0.91. We've got good cutoff points, pain to no pain, demonstrated through the ROC curve to be pain is 7 and above. Good inter-rater reliability and high accuracy. So that we used that data. All that was done with our Android app, so it was repeated. Same studies were repeated in the UK by Urbana Babakova using our iOS version. But a really interesting piece of research, which was completed by Elizabeth Sampson and others, published this year, was done in the UK in general hospitals. Interesting study because we've got people of not just Caucasians, which were almost all of our people, a couple of Asian people, and 14 people designated Black, and 6 others. So we get that multicultural component to it. Good inter-rater reliability, pain check versus pain check. Good internal consistency, but really importantly, we now get some data around the concurrent validity of pain check versus pain AD. And though it's somewhat low in relation to at rest, but there were low pain scores, so that's potentially the contributor. But these are more than reasonable in relation to post-movement. They looked at this is the symptoms management end of life in dementia scale, looking at convergent validity. So there was moderate agreement there, and discriminant validity in terms of there were higher pain scores post-movement versus rest. But the authors also made a really interesting comment, which you can see here. Importantly, that the ESIMOLD actually looks at discomfort that relates to other causes other than pain, whereas observational pain assessment tools obviously focus in that area, but pain and distress are difficult to determine. So, but the comment was that because of the findings that we had, that there wasn't that high level of the high level discriminant validity and the moderate convergent validity, that pain check might be better at distinguishing between pain and discomfort, which is non-pain related. And really that needs to be further investigated, but at least gives us some solace that what we're actually measuring in these people is most likely pain. So how have we gone from then? So 2019, we have a large aged care facility in Singapore commence with pain check. Our first client in December of 2019 in the UK, and then COVID arrives and we don't see anyone do anything for about 4 years, but we now hold about 10 to 15% of the UK market. And they're doing a lot of research in terms of clinical outcomes and the cost benefit in the various NHSs. Canada, we got regulatory approval in November of 2020, but we didn't get any clients because of COVID until 2023. We've done a number of clinical trials in hospitals in Western Australia, and we have a major study starting what's commenced at Edinburgh Royal Infirmary in Scotland now. We got our first client in New Zealand in August of 2021. And currently we have about 1,800 healthcare organisations, which represent maybe 10 to 15,000 aged care facilities in Australia, New Zealand and Canada. And we've completed 7 million plus pain check assessments. So we have data on 7 million pain check assessments. That's 150,000 individuals and assessments completed by about 16,000 trained pain assessment. And we've done a pivotal study in the US that was completed last year, and we're going through the process of a de novo application for regulatory clearance in the US, which is a long and drawn out process, but we will get there in the end. So this is just a little snapshot from a real world experience. As I said, the UK are doing lots of quality improvement reports, but we do have a couple of formal assessments of pain check being undertaken by different universities within the UK. And this group, over 20,000 pain assessments, a reduction in mild, moderate and severe pain, and as a consequence, without absolute causality, but an association, a reduction in hospital admissions, a reduction in antipsychotic use, a reduction in confusion, a reduction in falls, and we've got a number of centres reporting a reduction in falls, and they go hand in hand. A reduction in distress, which often requires one-on-one nursing, and a reduction in restlessness, which is a very high predictor of pain from the data we have. It's one of the most important predictors of the presence of pain. But really, this is the tip of the iceberg. So we've got our point of care application. What we know is the first thing is when people start Pain Check, they've got better documentation of pain. So it helps maintain documentation. We do provide training. When they had the Royal Commission into aged care in Australia, Pain Australia reported that only 41% of people who were caring for people in aged care had ever had formal training in assessment of pain in people with dementia. So that's something that we're adding to over time. We do improve communication, and one of the facilities in the UK says it takes 2 minutes to do a pain check assessment, and it can take up to an hour when you've got to use paper-based. We believe we increase that diagnostic certainty, and so we're certainly seeing this improvement in the BPSD, and with that, better reduction use of antipsychotics, but psychotropics in general. Better use of analgesics, and with quite a lot of reduction in the use of opioids, which is difficult in its own right because we think about withdrawal from those drugs as we need to think about the antipsychotics. I've already talked about reduction in falls, hospitalizations, and we do have a complete pain profile. And I suppose, what are we doing into the future? We've already started this. We're using our data to provide us with a better insight into what pain looks like. So we've looked at the faces of pain and dementia, and much of our findings support work that's been done by Miriam Coombs and Stefan Lontenbacher. We've looked at vocalization, and our data suggests that if you've got 2 or more pain-associated vocalizations, you're likely to be in high pain. And this data helps in the training of people. You can give flags to say, lots of vocalization, let's do a formal pain assessment. Let's see what's happening in those particular people. But the other thing that we're really interested in is this pain score. So I've got a pain score of 5. What's that really mean? A pain score of 5 could be incapacitating for me, but it may have no impact on anyone else. And the literature says generally people don't even seek pain management until it's above 4. Then we've got these intensities. So mild, moderate, severe, extreme. Again, that's telling me the intensity, but I don't know what it looks like in terms of what's the behavior, what's my impact on my emotional state, what can I actually do? And so we're interested in looking at pain profile, pain experience. So just as an example, and I've got one more slide after this. These are 2 people. This is John. He's 77, advanced dementia, osteoarthritis, unable to communicate his pain, and the carers suspected he's in pain. They've done a pain check, and his pain score is 14. It's moderate. And this fellow over here, David, has got Alzheimer's disease, has a recent injury, unable to communicate, same issue, same pain score. So at this point in time, if we treat the number or the severity, we're likely to do the same thing. But let's see what they actually really look like. So this is John. And let's forget we've got the pain score, but he's got his pain manifestation is this inactive, prolonged resting, fear of touch. He's introverted lately and avoids social interaction. So this person, in the absence of knowing is in pain, this is someone, I went to a conference the other day and it said 10 days in bed is equivalent to 10 years of muscle loss. So this person is going to die unless we realize that they've got a reversible cause of these things that manage their pain effectively. This person over here is different. He's abusive, aggressive, confused, distressed. And this person is very likely, in the absence of knowing they're in pain, to have an antipsychotic drug. He might then fall over, break a hip, and die as a consequence from that particular event. And, you know, many people say, well, they had dementia, they didn't have a good quality of life, but that's very unfair. everyone's got a good quality of life if you remember that you need to treat them. So this is what we're looking to do. We're trying to profile. We want to provide automated handovers to people so that we can communicate the issues and that we can follow up. And we're not trying to remove the experience and the knowledge of the person who is caring for them. Pain Check allows that hybrid of AI plus the clinical input, but we do want to ensure that we've got people thinking that there could be an antecedent that they're unaware of. I'm happy to answer any questions that you have.
The first thing is, we are working in a nursing home, and the 2 points you also mentioned was the resistance to care intervention, and the other point was sleeping problems. And do you see in your data, because you have now a huge database, do you see that especially these 2 items, if the person is resisting to care intervention or has sleeping problems, is a good or a reliable indicator for pain?
Certainly what we've done, and I haven't presented the data today, we've looked at all of the 42 pain indicators that we have. All 42 pain indicators have predictive value. Their presence has predictive value of high levels of pain. Remembering to have a pain score, so to have a moderate pain score, then you would have to have 12 to 15 items. So it's part of the multidimensionality, but certainly resisting care has a very high predictive value. As I said, restlessness has a very high predictive value.
Yep.
Within the voice, noisy pain sounds have a very high predictive value. So does sighing. So yes, and we're just at the moment we've got a manuscript in with Lancet Digital Health that it covers all that. So I hope that will be published in the near future, but we're all academics, so near future is whilst I'm still alive, but that will provide those insights into the items that have, when they are present, the probability that the person is in high pain is increased significantly.
Thank you. I would be really interested in that, because this is like what the nursing staff is always telling me, the resistance to care and the sleeping problems. So I could tell them, yeah, you are absolutely right. So what you experience is correct.
Yeah.
And I was also thinking about the pain is now a medical diagnosis. How do you, according to the ICD-11, how do you see that? Do you think that pain will become a more, how should I say, a topic that where a lot more people will go into research, so the interest is growing by becoming a medical diagnosis? What do you think about that?
I believe that there's an enormous amount of research into pain at this point in time. I think the really interesting component. So pain is subjective, and pain is what the person tells you you've got. All right. So we're all happy with that. But then people say, but we need an objective way to measure pain. We need to use facial analysis, using physiological parameters, and we combine them. And with that, we will have an objective measure of your pain, which sounds fantastic, doesn't it? You know, I know that you've got this pain. It says it's whatever, 16 pain amoms. But quite honestly, as a person who is then going to have the pain, and someone's telling you that what your experience is not what this is giving me as a number, to me frightens me enormously. It's interesting. It's become a diagnosis. It's frightening in some ways, and the way in which people want to make pain completely objective. I read a lot of literature about, you know, putting cameras in people's rooms and monitoring their pain, and has a system I was reading about the other day where it will alert when the pain goes above a particular level, and then the person can go and intervene with that. Now, I suppose, that's a positive, and a negative, because aged care facilities is not full of thousands of people to go and do those things. When my mother was in nursing home, I would go in and inadvertently step on her falls mat, and 10 minutes, I wouldn't turn it off because that would breach what should happen. And 10-15 minutes later, someone would arrive to find out whether my mother had fallen over. So I didn't see that as a particularly good outcome. If she'd had a stroke and needed to get to hospital to be thrombolyzed, that wouldn't have been a good outcome. So there's going to be a lot more work in objectivity of pain, and we then need to maintain the person within that, not eliminate those decisions. It's like someone having really low blood pressure and people saying, you must be dizzy all the time. And they go, no, I'm not dizzy at all. So we need to accept the heterogeneity of people and pain experience. And that's what we're actually trying to do. People will say not all of the items that should be covered that cause associated with pain. So bruxism, crushing your teeth, and many people do that as part of their sleeping because of pain. You can't include everything, but if someone says that's the best indicator of pain the person's got, you should record that and use it as the primary indicator.
Thank you very much. You were already talking about a lot of the items that are now included in the pain check. And I was thinking about, are you also discussing to shorten it down? So to think about the shorter version from 42 going down, because I know then it might be even more practical.
This is an interesting debate, all right? And I've seen the evolution of the PAC from 24 to 15 to 6. And so that's to speed up the process. And but the fastest way is for me to use my clinical acumen, and I go 2. All right, it's taken me no time at all. I've looked at you and I've said I've given you a result of 2. The issue of having a narrow group so that I'm able to detect pain is offset by actually understanding that the diversity of the types of pain experience that people have. And we would like to look and cluster to see, in the same way people have clustered facial expressions, of whether there's clusters in that way. I was just looking at the data on how long it takes to do a pain check assessment based on our global databases today, and the average time is less than 2 minutes to complete the assessment. Obviously, there's an observation component to it. So yes, we could reduce it. At this point in time, I think we're taking advantage of the large data set to then, if we do reduce it, then we'll use the science to reduce it to the items which are the most predictive. That's the way we will go.
Thank you very much. Are there any questions? What I remember from the last year, and I think this is really interesting, it's like we started last year with pain assessment, and Wilke Achterberg was talking the PIKE, and there's also a colleague from Brazil, they just translated the PIKE. And at the end, we had a discussion about if the PIKE, doesn't matter how many items, is really the right questionnaire, the right scale, because a lot of these subjective, emotional aspects are not covered by these items and scale. So it was very interesting. I had the feeling that within the group, there was this call for a more holistic picture. And as I can see it, or I believe I saw it right now, you included that, because you do not only make like the PIKE or a scale with so and so many points, 15 means moderate or even severe. You also include these profiles. And I think this includes these holistic pictures it's not only about pain and the pain score, but going beyond and having a look what is the impairment because of pain in terms of social, emotional, whatever. And I really, really like that. And I think there's a link between last year and this year, from the Pike to your pain check. So thank you very, very much.
Thank you.
I hope we just stay in contact. I will have a look at the website now even more precise. Yeah, because I will be interested to trying that also in Austria. So we might need the translation and things like that. So yeah, I think we'll stay in contact. And thank you very much, Jeff, to be our speaker today. It was really, really interesting and fantastic. Thank you very much.
Thank you. And as I said, look, we're very interested in working with other people and having independent people work and verify what we've found. And as I said, Kresnik lives in Kosovo, so he tells me he can fly anywhere in a minute. So certainly reach out. Anyone reach out. We're happy to provide interaction in that space. And thanks very much for the invitation. I very much appreciated it.
No, thank you very much, Jeff. Have a nice evening, and I hope you sleep well. Thank you and goodbye. See you. Bye.
All the best.